On the Go podcast.
He is a pilot, not only in an actual airplane, but also as researcher and orthopedic surgeon, discovering better patient care and navigating through toughest foot and ankle terrain. Markus Walther, medical director of Schön Clinic München-Harlaching and FIFA Medical Center Munich, with today's hot topic of the path to ankle cartilage regeneration, in a coffee break with our expert team member Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Taka Oshima, and this is On the Go, the podcast all around orthoregeneration.
Yeah, thanks for the introduction, Taka, and I'm very happy to be on the new podcast for the On the Go podcast. And today we have on the other side of the line Markus Walther, who just has been introduced. And as we usually start our podcast with the same question, I would also like to welcome you first, and then ask the question: how do you drink your coffee, Markus?
Well, normally I drink my first cup of coffee in the morning alone, because all other family members are still sleeping, and I have it with my iPad reading the newspaper, and that's it. And the second will be with my secretary when I'm in the hospital.
And the second is when you arrive in the hospital. How do you arrive at, like 7 a.m. or 6:30? How early is early for you?
6:30 is the regular time I arrive in the hospital, and then the whole hospital starts at about 7.
Okay, and then with your second coffee, you analyze the day, what's ahead of you, or what's on the schedule.
We look at the schedule. We look at important emails which arrived, and just making clear that she knows how to organize the back office during the day when I'm in surgery or outpatient clinic and whatsoever.
Yeah. All right. I think most of our listeners want to know a little bit more about you. You've been introduced before by our CEO, Taka. But could you tell us a little bit more about the place where you work, how you combine research and clinics, and where you're based?
Yeah, well, I'm based in Munich. I'm medical director of Schön Clinic Munich-Harlaching, which is the FIFA Medical Center of Excellence there. And clinically, I'm focused on foot and ankle. I stopped doing other regions of the body for more than 20 years now. And we have a quite big department just with foot and ankle, having more than 4,000 inpatients every year, only foot and ankle. We are 16 doctors just dealing foot and ankle problems, conservative, operative. We do everything from cartilage repair to total ankle arthroplasty, the bunion and the hammer toe, Achilles tendon, sports injury. We have a lot to do with professional sports. We take care of our national ice hockey team. We have close contact to several Premier League soccer teams, and basketball and ice hockey and rugby and all the sports which are common in our region, and in this time of the year, especially winter sports.
All right, and you mentioned that there's 16 different foot and ankle surgeons. If I understood correctly, what is your specific subtype of foot and ankle surgery that you focus on?
Well, I'm mainly focused on the ankle, from complex alignment surgery, supramalleolar osteotomy, cartilage reconstruction, osteochondral lesions, up to total ankle replacement.
All right. Yeah. So mostly focused on osteoarthritis and cartilage and osteotomies.
Yeah.
That's something that I'm very interested in as well. So I'm very glad to have you on the podcast, as cartilage is also one of my hobbies. Shifting to that, to the cartilage and the osteochondral lesions of the ankle, can you tell our listeners a little bit about what a cartilage lesion or an osteochondral lesion of the ankle entails and how you diagnose it?
Well, as the name says, compared to the knee, in the ankle, we have, in most cases, osteochondral lesions, which means that we have a problem with the bone and the cartilage. So that's, in our experience, a totally different story compared to superficial cartilage lesions or just cartilage lesions in the knee, because the underlying bone stock is a very important factor in the whole treatment concept. And a lot of treatment algorithms are driven by, well, the size of the defect and the depth of the cystic lesion, which is often found underneath these cartilage things. The diagnosis is normally, well, the patient presents with pain, and a lot of them you can see on normal x-rays, but most of the patients go and have MRI examination to see the cartilage, the ligaments, the bone edema, which is often found around these defects. Most of these lesions are at the medial malleolus in the ankle, and most of them are more dorsal than ventral. That is the typical setting for the osteochondral lesions in the majority of the cases.
All right, and you mentioned that you mainly use MRI for that. Do you also apply a CT scan in your clinic, or is it mainly focused around the MRI scan?
Well, a lot of patients come with normal weight-bearing x-rays of the ankle, so I have a good idea about the axis. Then normally I don't add CT rather than an MRI to have the second goggle on the problem.
Yeah.
If I have no x-rays, I normally do weight-bearing CT. We have this available in our institution, and that gives a lot of information about the whole ankle configuration and much more information just than plain x-rays.
Okay, all right. And when you Google your name in PubMed, you can see some research on the osteochondral lesions of the ankle, and mainly also with the German registry on cartilage lesions. And recently, you've published also in Cartilage Journal some publications on this topic, also focusing on the treatment strategies for the osteochondral lesions of the ankle. From your perspective, and mainly also regarding your clinic, how do you usually start with your treatment strategy? Could you take our listeners a little bit more deeper on your thoughts on this?
Yeah, it depends, and the treatment of cartilage lesions is mainly complaint driven. So a lesion we just see by accident on an MRI, which is done for another reason. Yeah. We would just suggest to observe that and make a follow-up after 1 year to see, for example, if a cyst is growing, but leave that alone. If patients come and have minor symptoms, conservative management definitely plays a role, also in our hands. That starts with modification of activities. We use hyaluronic acid, we use PRP, and recently we started to play around with these fat tissue-derived stem cells. Also, that's a very early phase of the treatment, but these are things where we are looking at to manage conservative. However, if a patient has persistent pain and he's limited in his daily activities, then surgery is definitely an option. And there we follow the algorithm which was recently issued by the German Orthopedic Association. I'm a member of the working group for tissue and cartilage regeneration, and we try to develop an algorithm as evidence-based as possible to treat these lesions. And the first thing we look at is ankle mechanics, which means we look for ankle malalignment and ankle stability. If there is a problem, should be always addressed together with the cartilage treatment. And then for the cartilage lesion itself, our threshold is about 1 square centimeter. Superficial defects below 1 square centimeter, we go for microfracturing. If they are bigger than 1 square centimeter, then we have good evidence that scaffolds are helpful and give better results. We are very aggressive with debriding of the cysts and bone grafting. In most cases, we try to really go for biologic regeneration, also knowing that the cartilage you can grow in the joint is often not as stable and sustainable as the original cartilage. But that is more or less our approach. If we have really big osteochondral fragments, for example, after injuries, and we have a chance to refix it, a big bone block to put into screws is mandatory. Then we would refix it with absorbable magnesium screws, for example.
Yeah. All right. So it's mainly also radiological and complaint driven, in which you take into account the size, patient complaints, malalignment, alignment, and then go from either watchful waiting to injection therapy to surgical therapy, minimally invasive to large invasive. And I think with regards to the last thing that we mentioned, going to the larger lesions, in which we really have to think of the osteochondral lesions as complex injuries. Besides the recent publication that you had with the German working group, a different publication came out on the AMIC procedure for the assessing the long-term outcomes for osteochondral lesions of the ankle. Could you tell the listeners a bit more about the AMIC treatment? Because at a previous podcast we had Professor Kerkhoffs on the podcast, where we focused a bit more on fixation and topic procedure. So I would like to ask you a bit more about the AMIC procedure for larger osteochondral lesions of the ankle, what it entails, and what the role of this treatment option is.
Yeah, as already mentioned, lesions larger than 1 square centimeter in diameter, we have good evidence that an additional scaffold improves the results. And the idea is to give the stem cells, which come out of the bone marrow, an environment very similar to cartilage, which directs them more to develop in the direction of cartilage, and to keep them in place and to cover the bone graft you put in. And so far, you find several scaffolds on the market. However, the AMIC, the Chondroguide, is the only scaffold where we have now 10-year results, and where it's proven that the clinical outcome seems to be stable over that long period. So the patients improve and they stay on that level for many years, and that is one of our major arguments to use this concept rather than others.
And AMIC makes use of a scaffold, as you mentioned. Can you tell our listeners a little bit more into detail how that specific system works, and how it works, for example, in comparison to applying only bone marrow stimulation? What is the reasoning behind it?
Well, the reason for the AMIC is that the stem cells migrate into that membrane, into that scaffold, and then they start to grow and to develop into a cartilage-like tissue. It's not 100% cartilage, but it's a tissue which comes closest to cartilage, looking at the things we have available today. We use it at the moment in combination normally with PRP and with autologous fibrin glue. You have to fix the membrane on the surface of the bone or on the bone graft, and you can do that either with commercial fibrin glue, but you have also the possibility to get autologous fibrin glue from the patient. And with these kits, you get, besides the fibrin glue, also PRP. So it makes sense to soak the membrane also in PRP to have the better biological stimulation of the tissue healing you can get.
All right, and that's usually now also applied in your clinic, as I can understand from your words. To what extent is adding the bone marrow stimulation versus adding the PRP versus not adding the PRP in the AMIC something that has been evidence-based? Has there been any clinical trials on that, or what's the grade of evidence around that?
Well, first, we use AMIC now for 12, 13 years. So we have published these 10-year results recently. And we have quite some experience on that concept. And in these days, the major argument for us was we use this membrane with the autologous chondrocyte implantation.
Yeah.
And then it was stopped by regularity issues in Germany. And then we shift to the membrane alone. And then we try to augment that with biology as much as possible.
Yeah.
So looking at the PRP, at the moment, there is no published evidence. We are looking on our data, and I'm sure we will come out with the first paper on that during the year. But in our experience, it makes sense.
Yeah. We're looking forward to the first paper in 2025. So we'll tick on the PubMed to see whether you when it will be published. So we're definitely looking forward to that. As I can understand from your words, there's many innovations that are coming out from the Munich department on biological treatment around cartilage lesions of the ankle. Just shifting a bit towards 2040, 2050 in your mind. Just take us with you. Trying to envision the future of cartilage lesions of the ankle and the treatment around it. Where do you think we will be in the year of 2040 or 2050 regarding this topic?
Hopefully further than today.
Yeah.
No, I think our focus should be, or has to be, to tell the stem cells better what they have to do. I think that is our major problem at the moment. We have the bone marrow stimulation, which works in the small lesions. When we have the bigger lesions, we keep the stem cells in place with the scaffolds. However, we see that they go quite far in the direction of cartilage, but they don't get 100% there. And if you have patients with persisting complaints and you scope them again, you see that the regenerated cartilage is somehow softer in the surface, and it has sometimes some small cracks. And these are things which can improve, but that's a more biological than a mechanical problem. And I think understanding better the communication between the cells, hopefully finding transmitters to tell the stem cells what they should do when they migrated to the AMIC membrane. That would be perfect. And in the ideal world, a future membrane would be soaked with these substances that the cell goes there and knows exactly what to do, and we have more or less normal cartilage several weeks later.
Yeah, that's going to be the future in your eyes, 2040.
I think that is the problem. When you look at the data, you see that you have a significant improvement in more or less all the patients. However, you see there's a kind of threshold around 85 something OFA score, which means they have still some limitations. And when you treat those patients, a lot of them come back say I'm much, much better. But when I go running on uneven ground, I still feel the ankle is not like before.
Yeah.
And that's the correlate to the softer cartilage regeneration we see. And hopefully we can improve that in future, that the cartilage moves more into the direction of really normal cartilage.
Yeah. And so you definitely described where we need to go, what the current problem is. Just imagine that an independent research grant will give you 10 million euros, and you can only spend it on answering this question or this problem. What will be the first 5 studies or research questions that you would like to have answered, trying to go towards 2040 or 2050?
Well, as orthopedic surgeon, I'm more the mechanic guy rather than the biologist or biochemistry. But I think I would focus on intercell communication. These things which control the cells, what they are doing. I think that would be the rough direction I would try to go.
Yeah. And in that sense, the future patient will look different visiting your office in 2040, in which we maybe draw some blood, and then we know from a personal perspective or from an individual perspective from that patient what he or she needs. Is that something that you also would focus on, like the individual perspective around cartilage lesions of the ankle?
I think the more individualization is an interesting thing to improve that. However, it will just increase the information we have, but in our experience so far, a huge problem in the ankle is just really mechanics, which exceeds the resistance of local cartilage, these chronic instabilities. And the more you treat them, the more you find mechanical problems always related to these cartilage issues. So adding the individual part is really interesting, especially just to burst biology in this individual patient. But I think the mechanic will not lose importance, definitely not.
That's interesting, because then you come back to your first comment on your treatment algorithm, that you always first look at alignment when treating these lesions. So in 2040, you will definitely take also into account alignment and instability as a first deciding factor for your surgery or for your treatment as well.
Definitely, yeah.
And then a bit more on the future, maybe of AMIC, because there's been many generations of AMIC in over the past I think 10 years. This will keep on developing. In what sense do you think it will change over the coming 20 or 25 years? What specific substances will change? Will the scaffold content change? Where do you envision this will go to?
Yeah. I hope we get to the point that we add to the membrane these transmitter substances to tell the cell where they need to go. I think that will be the major change. The mechanical problem to keep the stem cell in place, well, their AMIC is really an extremely good device. We started with these gels many years ago, which work well in the knee, but in the ankle you have always the problem that you have the talar shoulder, and that there these gels are not stable enough, and there this collagen membrane really gives the stability you need. So I think it will not disappear. Maybe we will have the option to inject it rather than to implant it with surgery.
Yeah.
However, there we see the problem that treating the bone defect is the major problem, not putting the membrane in. You can get the membrane in with a scope already today. That's not a big, well, it's a little bit tricky, but it's manageable.
Yeah.
But the underlying cysts, to get that really clear, to get all the soft tissues out and to graft it adequate, I think that's very difficult in especially the dorsomedial lesions, and because you cannot get around the corner. And that's often the reason, at least to do an arthrotomy. With our instruments, we can avoid osteotomies of the medial molars in about 95 to 97% of the cases. But arthrotomy is often needed to get really the curette in the place to really remove those cysts.
What you also mentioned is that it's definitely difficult to reach the subchondral bone with only an injection, which definitely makes sense. Treating the subchondral cysts is definitely almost not possible without a specific surgery, arthrotomy, or an arthroscopy. With regards to your experience with AMIC or your treatment options, do you see on a regular basis that the cysts come back after the AMIC treatment, or what is your strategy to prevent this reoccurrence of cysts?
Our strategy to prevent the reoccurrence of cysts is, first of all, really to get out all the soft tissue. And then we drill the sclerotic wall if it's there. And then we graft it. We soak the graft also with PRP, and then we cover it with the AMIC membrane. With that concept, we see reoccurrence of cysts in a small percentage. It happens. And when we see that, that is for us always a reason to step back and to think about maybe we need to unload that region, and we still have a stability or malalignment problem. Yeah. Which interestingly often really helps. If we see failure of AMIC, the revision is normally combined with alignment surgery to just unload that diseased area, and that works well in our hands.
Okay, that's interesting. That really suits the thought of the Amsterdam school as well. So I think there's many similarities in that sense. I think we've taken a good look to the future of 2040 and regarding ankle cartilage lesions, and I'm really happy to hear your thoughts and have picked your brain on that. Then we shift a little bit more towards your career path as an orthopedic surgeon and as a researcher, and we would like to ask you, especially regarding our younger listeners as well, to give some advice on how you get your inspiration for research and how your path towards your current role as a combined clinician and researcher has gone. What are your tips, and how has your path been?
Well, the first tip is forget about work-life balance.
Okay.
Now, if you really want to be good in both worlds, you need more time than the 35 to 40 hours the average German works.
Okay.
Well, if somebody is interested in doing research in Germany, it's definitely a good idea to try to make the orthopedic residency and training in a university hospital. Look for a research team, because there normally is the infrastructure and also the money to do some research and the connections you need to do that, starting with statisticians or language editing and all these things you need. And it makes sense that you join a research group dealing with the topic you're really interested in doing research just for becoming PhD, you can do that, but it's always more difficult to motivate yourself. If you have something which is exciting for you, it's much easier. And then, well, in the long run, it's a big question where you see yourself in 5, 10, 15 years. If you want to go direct or completely into the research part, there in our environment, it's more the pharmacy companies which provide these jobs, or the universities with the basic science institutes. If you want to combine it with hospital work, then you have to accept that, especially regarding these basic science topics, there will always be a lot of people around you knowing much more about that than you do. So I accept that. We have an excellent team, and I focus on doing the surgery, and I contribute to the research as far as I can. But looking just on the time, about 80% of my time is clinics and not research at the moment.
Okay, 80% clinics and 20% research.
And some hospital management.
And some hospital management. 80, 20, 20. I see, 120%. And regarding your research inspiration, you, as we talked about in the beginning of the podcast, together with the working group, you published some studies also in Cartilage. How do you usually get your inspiration for a new project which could be innovating and interesting for readers? Where do you get your inspiration from?
The inspirations I get normally from the patient, from their stories, from their problems. And when I come along a problem where I have the feeling we don't have a good solution, that normally pushes me to look if we can find something different, something better. And there, cartilage is definitely one of the hot topics. As I told you, they improve a lot, but they can still be much better. And to close this gap, that is something which is really exciting.
So in your daily clinics and in your daily outpatient clinic, there's a patient that presents with a specific question to you, and maybe say, "Oh, doctor, what are the chances that I return to this sport, or how come that I still cannot do this?" And that those are some questions that you get your motivation and inspiration from.
Yes, these patients come back, say, "Well, now I'm pain-free during daily activities. I can cycle, I can swim. This is all fine, but I want to play soccer. And when I started to play soccer, then I had some pain again. Then you do an MRI and you see some bone edema, and the cartilage is maybe still soft and does not resist the load you have while playing soccer." And thinking about how we get this problem solved, and to get really good regenerated cartilage is one of the definitely unsolved topics we have. And the older our population gets, the more important it gets to think about these solutions, because losing mobility is a huge problem.
I think getting the inspiration specifically and directly from your patient for research questions and to keep yourself motivated to get better on a daily basis, first of all in clinics and second of all in research, is a huge inspiration, and I think many people can recognize themselves in it. I think we've got to know you a little bit on the research side, but also on the personal side, where you get your inspiration from and how your path has been. We're slowly moving towards the end of the podcast, and we just like the beginning, where we start the question with how you drink your coffee. We always end with with some unexpected questions. And then your first one that I want to ask you is, what is your guilty pleasure?
Oh, spending the day in the mountains with a mountain bike, knowing that I have to work on some papers.
Okay, that's a guilty pleasure, but also not a guilty pleasure.
No, really getting things together and getting some balance in these in these days. There's a continuous challenge.
Yeah, I understand. And then sure, you have many mentors or people who inspire you, but just a little bit outside of the box. If you could choose one person, he or she could be dead or alive, that you still want to have a coffee with, who would that be?
Well, an interesting person would be definitely Jesus Christ. Just knowing, is it all true or not? Because we have a lot of trouble about religion worldwide, and having a cup of coffee with this guy would be really interesting to get some clarity on many questions mankind drives around.
I think it's a great answer, and I think many people would want that. And if that could happen, please let us know what the answers were. Thank you very much, Markus, to be on the podcast and to have picked your brain on your treatment algorithm of cartilage lesions of the ankle, but not only that, also the future of cartilage lesions of the ankle, and to have got to know you a bit better on the side of your inspiration for research and clinics. And we wish you a lot of luck regarding your future trips regarding the research and clinics on this. And thank you once again for the inspiring conversation.
Yeah, thanks for the invitation, and we go on regeneration.
Yeah, that's it.
This was On The Go, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening and have a great day.